Hello and welcome everyone to our first public webinar of 2019. I'm Brenna Rabel and I oversee education and outreach on the Measures Management System contract, which is funded by the Centers for Medicare and Medicaid Services, or CMS. Today's presentation, Measuring Quality to Improve Quality, is intended to provide an overview of clinical quality measures and how they're used by CMS. We'll talk about the strength of quality measures in driving healthcare quality improvement, as well as some of their limitations and challenges. I'm joined on the call today by Kim Rawlings, who is the CMS lead for this contract, and Dr. Nicole Brennan, who serves as the Senior Project Director for this work. You'll hear from each of them later on in this presentation. So before we dive into today's topic, I want to take a moment to talk a bit more about this public webinar series. These webinars are part of an ongoing effort to engage measure developers, consumers, and other stakeholders in quality measurement topics, an effort that also includes a series of newsletters and bulletins, monthly information sessions, and routine updates to the Measures Management System website. These webinars typically occur over the summer and focus on broad topics related to quality measure development, intended to help introduce those who are new to this topic to key concepts and to orient stakeholders such as patients and frontline clinicians to the work being done around quality measures. In July, we'll do a second set of presentations on patient-centered quality measurements, explaining how and why measures are supposed to be patient-centered and how patient feedback is used to shape the measures being developed. We hope you'll join us and that you'll share the opportunity with others that may be interested in learning more about these important topics. We certainly encourage sharing these announcements with your colleagues or members of any professional organizations you belong to. And feel free to reach out to us at mmssupport@battelle.org if you have any questions. Now, a couple more things before we jump into today's presentation. First, today's session is being recorded for note-taking purposes. Second, this presentation is offered in a broadcast-only format, which means you'll not be able to unmute yourself to ask questions. If you do have a question at any time throughout the presentation, please type your question using the Q&A feature or the chat box in WebEx. We'll queue your questions in the order they're received, and we'll do our best to get to all of them during the Q&A period later in the call. And finally, the presentation slides from today's session will be posted to the MMS website at a later date, and we'll also post a recording of today's presentation on the CMS YouTube page. So here's the agenda for today's call. We're going to start with an introduction to CMS and the MMS system, and then we're going to talk about how quality measures are used and how they're developed, and take you through the life cycle of a quality measure. And then we'll talk through the strengths and limitations of quality measures before turning it over to Kim Rawlings from CMS to discuss the Meaningful Measures Initiative, and then over to Nicole Brennan to talk about some key resources. So as I mentioned at the beginning of the call, these webinars are developed under the Measures Management System contract, which is funded by CMS. So CMS developed the Measures Management System to help standardize processes and criteria that guide measure development and measure maintenance, specifically for measure developers that are contracted with CMS to develop measures for CMS programs. Chiefly, the purpose of the MMS is to enable measure developers to create and maintain quality measures that drive CMS's quality goals. We work to standardize measure development processes to ensure consistency and comparability of measure specification and testing approaches, but we try to allow for enough flexibility in these processes to allow for innovation in this work. We're also focused on improving transparency about how measures are developed, selected, and used with stakeholders, including frontline clinicians and Medicare consumers. As the Measurement Management System contractor, one of our key responsibilities is to maintain the CMS MMS Blueprint, which is the publicly available document that guides measure development. The blueprint is comprehensive. The current version clocks in at nearly 400 pages, and it includes detailed information about every phase of the measure lifecycle, as well as timelines and templates to support measure developers as they embark on this work. You can find a link to the blueprint via the Measures Management System website or by Googling the CMS MMS Blueprint. The MMS website also includes information highlighting best practices, references, guides, and links to past webinars, and relevant forms and templates. Nicole Brennan will talk more about this and other MMS resources later on in this presentation, so I won't spend a lot of time on it now. So that we've oriented you to the work being done under the MMS, let's dive into the topic of the day, which is CMS quality measurement. This quote from the National Academy of Medicine tees up this discussion nicely. Quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with the current professional knowledge. So put even more simply, we think of healthcare quality as being the extent to which patients are achieving good results and that the care they receive is aligned with the most up-to-date and evidence-based guidelines available. So what then is a quality measure? Well, a clinical quality measure, or a CQM, is a tool that quantifies exactly that. CQMs quantify healthcare processes, outcomes, patient perceptions, or organizational structures. They are, by definition, associated with the ability to provide high-quality care and or are related to quality goals for healthcare. They must also be supported by good evidence, meaning that there must be information in the peer-reviewed literature or in clinical guidelines that aligns with the measure's intent. Now, I realize that this definition may be somewhat esoteric, but I promise to share an example of a quality measure in a few moments that will make this definition much more concrete. But first, let's talk about the purpose of CQMs. Why use them to measure healthcare quality? CQMs are associated with two kind of main goals. First, to improve the quality of the healthcare provided to patients by being a tool that guides good decision-making. And in this case, a good decision is one that makes it more likely that patients and their providers will experience a good result and make it less likely that they'll experience an adverse one. If a clinician or a hospital discovers that they're performing poorly on a given quality measure, they can choose to allocate resources to make changes to their practice to become high-performing. And because the measures are based on clinical guidelines, we can assume that a clinician or hospital that performs well on a measure is providing high-quality care in that clinical area. Second, CQMs can be used to empower patients to make informed decisions about where to go for care. Some quality measure results are publicly reported and can be found in places such as the Physician Compare or Hospital Compare websites, and this information can be used to guide decision-making when selecting a provider for a specific condition or treatment. Now, with that in mind, not every quality measure is used for this purpose, and CMS is still working on improving the ways that patients can use measures for that, but it's nevertheless an important aspect of CQMs and their use. So with that in mind, CMS uses CQMs in three primary activities. First, in their quality improvement efforts, CMS uses measures to track and promote healthcare that aligns with current and evidence-based practices and guidelines. Second, in their public reporting program, so measures that are publicly reported serve the purpose that I described on that last slide, to inform decision-making by consumers, but also employers, physicians, and policymakers by making measure performance information available for their use. And third, CMS uses measures in their pay-for-reporting programs, which means that clinicians or hospitals are paid based on the measures they report on. These programs are intended to increase accountability for the quality of care provided and to promote practices that will advance value-based purchasing models. Now, value-based purchasing models, in this case, refers to models that are aligned with pay-for-performance, where clinicians or hospitals are rewarded for providing higher quality care that aligns with best practices or that enhance patients' experience. So let's talk about the relationship between quality measurement and quality improvement. These two concepts go hand in hand, and both are necessary to achieve CMS's goals and priorities, but they're distinct from one another. Quality measures are used across practices and health systems for accountability, payment, and to promote informed decision-making, as described on the previous slide. Quality improvement, on the other hand, refers to any learning, culture change, and capacity building that's done in a specific setting or context. So quality improvement often refers to how specific organizations or health systems improve processes or outcomes in their facilities. Quality measures can help drive that improvement on a micro level by shedding some light on the areas of lower than average performance for such organizations and then driving them to make changes. And then quality measures can also drive improvement on a broader scale by incentivizing organizations to adopt care practices that align with certain guidelines or evidence. So I mentioned earlier that we would come back to an example CQM to better explain what they are. So we'll start with a basic list here of some measure components. In their most simplistic form, a quality measure is essentially made up of these three things. There's the numerator, which is essentially the measure focus, or the thing you're measuring. The denominator is the overall population being evaluated by the measure. So for example, in some Medicare measures, the denominator could be all patients 65 years of age and older. And then finally, there's measure exclusions. These are patients that should be removed from the measure population before determining whether the numerator criteria are met. Of course, measures have a number of other components that dictate how they are scored and what patients are included in their calculation, but for the purposes of today's discussion, this is a good snapshot of a measure's composition. And you can see a visual depiction of that structure here on this slide. So here's an example of an actual measure that's used in a CMS program. It's worth noting also that all measures have a measure title, and this one is called Diabetes Care Foot Exam. So the numerator, or measure focus, is patients who received a foot exam during the measurement period. The measurement period is typically a given calendar year, so 2018, for example, though this does vary. And notice that the numerator here allows some flexibility for the type of foot exam that would satisfy the measure. The denominator, or the population being measured, is diabetic patients between 18 and 75 years of age who have visited their doctor at least once during the measurement period. This measure also includes two exclusions: patients who have had bilateral amputation or separate amputations of both the left and right lower extremities before or during the measurement year, and patients who were in hospice care during the measurement year. I like this example because I think it provides a good illustration of how measure exclusions work. So take that first exclusion. By excluding patients who have had both lower extremities amputated, providers aren't penalized for not providing a foot exam to a patient for whom that would be not only inappropriate, but impossible. So essentially, exclusions ensure that only the patients who should be included in the measure are. So now that we've covered what quality measures are and how they're used, I'll summarize some of the strengths and benefits that I alluded to earlier in the presentation. So big picture, CQMs allow CMS to assess and reward quality of care for conditions that affect millions of Americans, things like diabetes, heart disease, and infection. CQMs also help increase and improve accountability as it relates to the quality of care that's being delivered. Quality measurement also helps promote and track improvements in performance over time, which allows CMS to assess the extent to which care quality is changing and to identify emerging issues that need to be addressed. And finally, by promoting measure development practices that are transparent and rigorous to produce measures that are scientifically sound and based on strong clinical evidence, and then using those measures in its quality programs, CMS is driving progress in aligning care with clinical guidelines and best practices. With all that said, though, quality measurement is also associated with a few key challenges that are worth noting, namely that clinical quality measurement is still a developing field, and that's driven and limited by the data available. So measures will become more sophisticated, meaning they'll be able to capture more nuanced information about patient outcomes or experiences as the technological capacity improves. Additionally, and more concretely, rare conditions can be difficult to track using quality measures. For conditions that only impact a small number of patients, measure numerators are frequently too small to fairly calculate a performance score or to make any inferences about the quality of care delivered on a national scale. So this isn't to say that CMS doesn't think these conditions are important to track and address, but quality measures may not be the optimal approach to tackle these types of things. CQMs are also pretty expensive and labor-intensive to develop and maintain, due largely to the extensive testing and evaluation that's required to ensure that measures are reliable and valid. So in other words, CMS needs to invest lots of resources to make sure that their CQMs measure what they purport to measure and that the measure results can adequately detect differences in performance across practices or hospitals. So this is, indeed a pretty notable challenge. However, this investment is crucial to ensure that CMS is relying on thoroughly researched and vetted measures in their programs. But that said, there's always the efforts being done, both at CMS and within the MMS, to try to make that process more efficient. And finally, the clinicians among you will know that CQMs are associated with a certain amount of burden to implement. So in order to report on a given CQM, a clinician or hospital may need to make changes to their workflows or their data collection processes to enable that reporting. And these changes can be costly and time-intensive to make, especially in light of the number of measures that any given clinician or hospital is required to report. So CMS acknowledges these challenges and has taken a number of steps to minimize the burden associated with implementing its measures. So for example, CMS requires its measure developers to conduct extensive feasibility testing to identify and mitigate potential reporting challenges. And CMS also promotes measure harmonization and alignment to try to streamline the information that clinicians are required to report. But nevertheless, it's a challenge, and we're constantly working to improve those processes to mitigate it. And with that, I'd like to turn the presentation over to Kim Rawlings from CMS to talk about the Meaningful Measures Initiative, which is helping to shape the future of CMS quality measurement. Kim?
Thank you, Brenna. As the lead of the Measures Manager for CMS and a member of the Meaningful Measures team, I'm just going to give a brief overview of the initiative to try and just help give some insight on how CMS prioritizes measures and measure development and quality improvement areas. So it's really important for us at CMS that we are improving outcomes for patients, reducing data reporting burden and costs on clinicians and healthcare providers, as well as really focusing our quality measurement and improvement efforts to better align with what is most meaningful to patients. So in October of 2017, CMS launched the Meaningful Measures Initiative to really help us achieve these goals and really improve our approach to quality measurement and improvement. And so this initiative helps us set priorities for not only developing measures, but also evaluating the measures in our programs for either possible removal or for adding a new measure or a quality improvement initiative, and really with the ultimate goal of prioritizing and focusing everyone's efforts on the same areas and lending specificity to our measure sets. So by using meaningful measures, we hope the measures in our programs will really embody the following attributes. With the added focus and specificity, we want to ensure that our measures, that we are identifying quality measures and improvement opportunities that are really patient-centered and meaningful to patients, clinicians, and providers. And with that, we feel like that will lead us to having more outcome-based measures that really have high-impact opportunities that safeguard public health while still identifying significant opportunities for improvement. We want to make sure that we're addressing measures and improvement activities that are value-based and, most importantly, align across programs and across payers, all while keeping in mind that we do, as a government agency, have statutory requirements that we need to fulfill for each of our various programs. And at CMS, we believe that achieving these objectives will really guide us to having measurable improvements for the nation while also encouraging the use of more parsimonious measure results and working to reduce the burden of measurement for clinicians and providers, and ultimately improving the quality of care for our patients. And so with the help of our partners, we identified key common issues to really focus on. And so CMS introduced over the past several years a comprehensive approach using the Meaningful Measures framework to really identify those areas of highest priority of quality measurement and improvement, and to assess those core issues that are most critical to providing high quality care and improving individual outcomes. And so as part of this initiative, we have a framework to help us focus on these specific high priority areas for measurement and improvement across all CMS programs and initiatives. So I definitely encourage you to study this in detail later, but I'm just going to start by quickly talking through this, and then we'll go through an example in a little bit more detail. So hopefully your eye is drawn immediately to the center of this, where we have our visual of our patient, because that's really what is at the center of everything that we do here at CMS, and them along with the clinician and that relationship, and making sure that they have the time to build that relationship. So along with this depiction of the patient-clinician relationship, you will also see the 4 CMS strategic goals: improve CMS customer experience, state flexibility and local leadership, support innovative approaches, and empower patients and doctors. And these goals serve as the foundational principles of everything that we do. Around that, we are connected with the 6 cross-cutting criteria: eliminate disparities, track to measurable outcomes, safeguard public health, achieve cost savings, improve access to rural communities, and reduce burden. And these cross-cutting criteria really serve as desired outcomes at CMS, as well as our partners, believe are critical for improving the health outcomes of our patients and really the overall health system of our nation. Around the 6 cross-cutting criteria, you will see 6 pictures, and those align with our health care priorities, which are in bold on the right, followed by our 19 meaningful measure areas. So each priority and area tracks to the cross-cutting criteria, and so I'll show you how that works here. So as an example, we have a cross-cutting criteria of achieving cost savings. So how do we do that? We can look at the healthcare priority, make care affordable, and this healthcare priority has 3 meaningful measure areas underneath of it: appropriate use of healthcare, patient-focused episode of care, and risk-adjusted total cost of care. And by working on these 3 areas and having good quality measures in these 3 areas, we believe that will improve and make care affordable, which will help us achieve cost savings, which will ultimately bring us to achieving and working towards our 4 CMS goals and improving the relationship between the patient and provider. So I'm going to walk through an example in a little bit more detail here. So we have our health care priority of promote effective prevention and treatment of chronic disease, and underneath of that we have 5 meaningful measure areas: preventive care, management of chronic conditions, prevention, treatment, and management of mental health, prevention and treatment of opioid and substance use disorders, and finally in this category, risk-adjusted mortality. And here in this diagram we have several examples of measures along with the programs that those measures are implemented in as an example. So if we look at, for an example, prevention, treatment, and management of mental health as a 3rd area under this priority, it's really important. We have, 1 in 5, or approximately, 45 million adults that experience mental illness in the United States. And so it's really a key area that if we put our focus and really align across our CMS programs as well as payers to have good quality measures under this area, we can really make a big difference. And like I said, this really embodies the work not only of CMS but across several other organizations as well. So with that, I am going to turn it over to Nicole to cover some information about resources.
Thank you, Kim. So one of the primary goals of the Measures Management System is to provide all stakeholders with the resources you can use to feel more connected to the clinical quality measure process. So following today's presentation, I would really encourage you to check out 2 of our websites that I'm going to mention. First is our CMS MMS website, which you can easily find if you just type in CMS MMS into your favorite search engine, as well as please take a look at our CMS Measures Inventory tool, which is lovingly known as CMIT, C-M-I-T, which can be found at cmit.cms.gov. So let's start by taking a look at the MMS website. You can see that going across the top here, we have broken up the website into 6 primary categories. First, the MMS overview, which includes more information on development, how you can get involved, tools and resources. And then finally, we have our section on new to measures, should you be brand new to how to develop a clinical quality measure, and then popular links. So on July 24th and 25th, we're going to be holding the second part of our series, which will include a more detailed description on how you can be involved in the measure development process. But the primary takeaway is that the measure development process really has a role for everyone who's on the webinar today. We need more patience in our technical expert panels. We welcome public comments to the measure development plan and measures as they begin to go through rulemaking. And here on the website, you can find a link as well to the MMS listserv, which will allow you to receive a monthly newsletter or bulletin from us letting you know about upcoming events, new measures being released, as well as new technical expert panels that are accepting members. Then taking a look at our CMS Measures Inventory tool, we have spent several years really transforming the measures inventory from a spreadsheet containing 10,000 cells of data to this interactive web-based tool. CMS was developed to really increase the usability and the transparency of the inventory for you. Within CMS, you can search for measures based on any number of criteria. So you can search for measures based on their condition. If you're interested in finding all measures that address cardiovascular disease, you can do that. You can also look for measures depending on what stage of development they're in. So if you're interested in knowing what measures have been proposed to CMS to be added to a program, you can search by that. If you'd like to know what measures are currently being used in any CMS program, you can search by that as well. You can also filter by measures that have been endorsed by the National Quality Forum. And you can search for measure just by what program they are in. So if you're interested in the QPP measures, you can search for those. Once you found the measure that you're looking for and you clicked into it, you're going to find all the attributes of that measure that stay the same no matter what CMS program they're being used in. So as Brenna was describing, you're going to find the numerator, denominator, and the exclusion criteria. You'll also find the NQF number if it has gone through NQF endorsement so that you can go over to that website and find it there as well. And you can look to see how the programs are using the measure. Are they currently using the measure, or do they plan to use the measure in the next year or two? Or have they used the measure previously and since then it's been retired? You can also find links to the federal rules associated with each measure. If you are interested in looking at those rules and seeing the comments that were submitted along with the measure, we have tried to make that as easy as possible for you as well. While on the MMS website, you can also locate the MMS blueprint. As Brenna noted, the blueprint really comes in at 376 pages, which can seem very daunting, but is not designed to be read from front to back. We designed this to be used as a guide to the measure development process throughout the process. So we've broken the blueprint into 6 sections. Section 1 and 2 combined really are just 30 pages long, and they provide you with a high-level overview of MMS and the measure lifecycle. And then Section 3 is where we begin to do the deep dive into topics such as person and family engagement, or measure testing, or measure evaluation. And then Section 4 provides developers with the forms that they need. If you are beginning to develop a measure as part of maybe a specialty society, you can look at these forms and get an idea of how to develop a business case for your measure, or what kind of information might be needed if you were going to submit the measure for CMS to consider to add to one of their programs. And then Section 5 is a glossary and a list of the acronyms that you'll see throughout the blueprint. The ECQI Resource Center is a great resource for anybody who is developing electronic quality measures. So they really consider it to be the one-stop shop for stakeholders engaging in electronic quality improvement. The site contains resources put there from CMS, as well as the Agency for Healthcare Research and Quality and the National Library of Medicine. and it's supposed to be used for you to find resources that can be used at the various stages of electronic clinical quality measure development, such as testing and certification, as well as continuous evaluation. Also encourage you to take a look at the National Impact Assessment. This assessment is published by CMS at least once every 3 years. The 2018 report was divided into 9 chapters looking at the impact of specific measure types, such as measures addressing person and family engagement, as well as it includes a discussion on the overall trends for CMS quality measures and how they impact the nation. And it also includes key indicators and how they were selected by technical expert panels and how patients also helped inform that process. Finally, I just want to re-highlight the Meaningful Measures Framework website that Kim has mentioned. You'll find videos and additional resources on this website that can go into more depth on what meaningful measures are and how they're currently being used throughout CMS.